Netflix on the screen, healthcare in between, physics, art, and math got us down this path. Historical tales come alive, where science and stories dive, blended facts with heart, knowledge from the start. Need bridge blues we sing to the future memory. Health and science in the mix, Maybrick's got the fix. Complex subjects make
right
clear
now
every episode
in ways that we actually acquire
leads the way,
and ways that make me more efficient.
in the world of digital streams, turning knowledge into dreams. Through the tales of old, new stories unfold.
Thank you so much for joining with me. It is truly an honor and a privilege.
MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming.
Hey, welcome to the MedBix Webcast. This is Raman Annamaraju. I'm the host. I have a co-host now, as you know, that last week she joined with me. So she is actually, let me tell you, she is a better looking, better talking. And then my camera is autofocus. I think whenever I move, it is acting up very strange. Okay, sorry, bear with me. All the technology things, I should not have messed with it. I messed with it today. So I'm not going to move too much. But anyway, she saves lives. She's a founder of Rescue RN, CPR training program. And then while she's not saving lives, she raises cattle, So she is nowhere, no man's land. She's joining from North Dakota, no man's land, alien land for us. Welcome, Susan. Where is that? Let me bring you. Let me bring
Am I
you.
on?
Yeah, you're
Good
on.
evening. There we go. Thank you, Ramana. Nice to see you.
Nice to see
Yes,
you.
coming to you live from North Dakota. I'm right here outside of the Badlands. Just an amazing rural spot. Wonderful healthcare system here. I've been working with, doing some training with their team. So I love it.
Oh, interesting. Yeah, that's you always are passionate about training. Last night, I went to Stanford Innovation Inspiration Summit. It's called, very big name. It's a Stanford. A lot of AI people came from all over the world. Actually, came from all over the world. The summit was excellent. They're talking about artificial intelligence. So I am going to play a clip from that scene, and then our guest may relate to that this one. So then after that, I'm going to introduce you our guest. Okay, let me do that. Media, yeah. That I don't know what I did. Something is
You did something.
Yeah, I did something horrible. So this one video, yeah.
I mean, if you think about healthcare right now, most of the time that research progress is stymied, slowed down because of access to data. If you can somehow look at all the data in the world, I would argue that you can solve most health problems overnight. but clearly you cannot centralize all that data. But if you have all these micro agents working on data that's distributed all over the world, then in fact you can centralize the intelligence by asking all these micro AIs. But although you cannot centralize that data.
Ramesh, you are going against the grain of Silicon Valley, the big companies. You're trying to do micro AI, giving a power to the individuals.
Right.
How does it work in this world, the practical world?
I think we need the big AI companies to actually solve these problems. I think the big AI companies are actually going to create these smaller models as well, but we're going to train all these models on our own data. So the products might come from big tech companies, but the way we train those AI models will be done it by ourselves.
Thank you, Ramesh. It's wonderful. Yeah.
Okay, this is, let me remove this and let me introduce my guest. You want to introduce Dr. Erkeda DeRouen. That's a French last name she has. She is joining from Washington, D.C. So until my camera is fixed, I think Susan should do that all the talking now today.
No, you're fine. You're fine. Listen, that was a very timely clip, and you were there just last night. So I'm sure Dr. Rowan has a ton to weigh in on that discussion.
Yeah, because I tell you, she is a triple boarded certified. She is a board certified in family practice. I don't know if she delivers babies or not, but that's they do that. Family practitioners, lifestyle medicine. That's a new. It's a very big right now. Lifestyle medicine is a prevention is a key, and what kind of things you're eating and all those things that are important. And then she's a diversity medicine. That's a very new thing. I never heard about it. She has 3 certifications and then 18,000 followers per her. Oh, Jesus. She got a lot of followers. Although there is no topic she didn't touch. I was watching her program, AIs and everything. Yesterday, she was talking about Nanda initiative. One of those videos, she is talking about Nanda. Let me bring her and Dr. Oh, yeah. Let me bring Dr. Kara, Rowan, right? Did I say right?
You
Yeah.
did. It's Erkeda DeRouen. So you said it correctly.
Okay. So tell us a little bit background and then we talk about, you did some video on Ananda. That's why I was very much interested. So tell me about a little bit about your background, where you went to school and you went to, I saw that you went to great schools, just to tell us all your certifications and all your lifelong learning.
All of it.
Lifelong. I don't
All
think we
of
have
it.
time, but I'll try to keep it brief. I really appreciate you guys for inviting me, and I'm very excited for the conversation. But I'm local. I born and raised in the DC area. I ended up going to undergrad at Hampton University, where I studied biology, pre-med type thing. I did a joint program where I kind of matriculated into the medical school at Boston University. It was a program where we spent our summers in college and then our entire senior year at BU taking medical school courses. So it was really interesting to kind of have that experience of having different people from so many different backgrounds come together, because it was kind of like a real world experience through that program where they picked 15 strangers to live in a brownstone together. So a lot of them are my best friends now in all different specialties. But for me, I decided to go into family medicine after leaving Boston University School of Medicine, and I did residency at University of Maryland in our family medicine program. I heard your comment earlier about delivering the babies, and we do have a requirement to deliver babies in family medicine residency. And I don't know about the people watching this, like there's medical terms like black cloud, white cloud. I was literally the black cloud. So I can say for the entire 3 years, I probably spent the most time in the L&D room. So now I don't do that anymore. I delivered quite a few babies, and it's very interesting now because like on LinkedIn or Facebook and things like that, you'll see some of my past colleagues who I work with, some of our medical assistants who I helped deliver their babies, and they're like big little teenagers. And I'm like, oh my goodness, this is crazy. So after that, I ended up doing the National Health Service Corps, because when I started my career, I always thought that I would be doing underserved medicine and kind of helping people navigate through community health, because a lot of the programs that I worked with were really big in community health and serving people. And where I grew up, there's a big need. So I did the National Health Service Corps, where I ended up working at a federally qualified health center. And I will say that that was a very interesting term for me because I really, really love the patient care. But it's where I learned about my love of leadership and administrative things. That kind of sounds weird. When I first started, I was kind of voluntold as the new girl to represent all 5 clinics for all of the doctors, as they decided to unionize. And I didn't even know that doctors could unionize. So that was an interesting 2-year experience of navigating from the clinical aspect of what employees need, what they want, how to do schedules, all of that stuff, and how to retain employees and have a delightful experience where there is a lot of engagement, but also from the C-suite side where, yes, we want to make our employees happy and all of those things, but how do you do that while also pushing the mission forward and working with the budget? So that was very interesting, and that kind of led me to finding out about digital health and telehealth before it was cool, before the pandemic. And I ended up diving into digital health probably about 8 or 9 years ago. Crazy that that's almost been a decade, and I've had varying levels of leadership. And I started working with teams where I was working with the product development team, and I kind of learned how an idea becomes a product feature, and how do you marry that with clinical excellence and quality, working on quality teams. And through that, I realized that I really had a strong desire to make sure that organizations are crossing their T's, dotting their I's. So I transitioned into consulting, where I've worked as fractional chief medical officer for a few organizations, more on the startup side. And I went and I got a healthcare risk management certification, and seeing just how in these times, like, healthcare is a risky business, but digital health is even riskier. So now a lot of organizations are kind of piling on these features, and I love to try to help healthcare build a safer system where we're incorporating digital and AI tools while also simplifying that risk.
Let me stop there. Yeah. So I saw the latest video. I want you to comment on that. Nanda Initiative. This is founded by my friend Ramesh Raskar. Is a friend of mine. He is the founder of that organization. They released a study saying that 80% of the all the major companies starting AI, they failed. Right, that's what you're talking about. But you're not against Nanda. I don't know whether you're a friend or foe or for my friend, but tell me a little bit about Nanda Initiative. I tell you what he wants to do, just to understanding what his plans are. I was so impressed. What he's going to do is every phone becomes a mini AI agent. That's what, so they become basically guide you through the process everywhere, all those things it does. That's what he was trying to do. So then eventually collect all the data, voice data, then all the text data and all the pictures, and then come up back. So that's a Nanda Initiative released that study about that. That's a big news in the healthcare community and the AI community particularly. So you did talk about access a little bit. Tell me your views on AI. What do you think? Where it fits? Where it doesn't fit? Where do
Mhm.
you think immediate? So I want to listen to your idea about the AI.
I think there's a lot of promise with AI, but AI isn't new. We've been using it for a long time. I think it is something that's very popular at all of the conferences, at least for the past 2 or 3 years, where we're thinking about different ways in which we can use machine learning and other tools in order to have a toolkit in order to help people do things more efficiently, hopefully more effectively, and kind of work at the top of your licenses, if you say. From the article and the discussion about why a lot of AI initiatives fail, I think that it's kind of the way that we're thinking about what AI is. It's a shiny new object. I think we have to take a step back, especially in the healthcare realm, and think about technology because it's going to change. A few years ago, it was which EMR system are you going to use? Now, is which AI tool are you going to implement? What voice to text kind of transcriber are you going to have? But we have to think about how can we create systems to incorporate things to help and use them as an adjunct to care. And a lot of teams are looking to see what Mayo Clinic is doing or what Kaiser is doing. And they're doing some great things, but how can you do it in your smaller health system? How can you vet vendors that work for the population that you serve? What kinds of data are you collecting? I know you just mentioned a lot of things that sound very exciting about using these tools and creating these data sets from what people users are using, but then you have to think about healthcare in that privacy era. Like we've seen what's happened with United Healthcare over the past year or two, where we've had several breaches that have cost like $850 or million, like that kind of thing, and then building trust with patients with all of the data breaches. So how do we protect data? And it wasn't just United Healthcare. There have been many stories recently because a lot of the systems are having more scrutiny on data sharing because we are integrating with these vendors, for instance, like GoodRx or the FaceBack apps. Like when people are coming on some of these particular telehealth apps and they're looking for Viagra, you shouldn't be seeing Viagra ads when you're looking on Facebook after that. So there's that data sharing and that privacy. So how do we innovate and move things forward so that these systems won't fail? Is that through pilots? A lot of organizations are doing that. Or is it they're taking a step back and just thinking about how to create these systems and incorporating any kind of technology, whether or not it's AR or not?
Yeah. So what you're saying is there needs to be a ton of vigilance, and it's very difficult to standardize. We need standardization, but how do you standardize when it changes every 10 seconds? So
Yes.
keeping up with that, and what does even compliance mean in this era in healthcare? How can you be standardized and be compliant when the workflow with these new, is it solutions we're talking about or outcomes? That's my new terminology these last few days as I'm just reading and keeping up on things. I'm wondering how much are we doing is actually about, because we have lots of solutions, but are they getting the outcomes that we're after?
Exactly. I agree. It feels like there's some kind of like shiny object syndrome. Like, oh, that looks cool. Oh, this. What if we do this? Let's put $1 million into this. But what, like you said, what are we trying to solve? We have to go back to what is our problem that we're trying to solve and how will we get there? Hopefully, we can incorporate new tools to make it better and easier and more efficient and have better retention, all of the things that organizations are looking for. But the ultimate goal is hopefully to serve patients and to make sure that they're having quality care that is safe. I think Ramana just also mentioned about my comments on one of the videos about access. So recently, I was at one of the digital health innovation summits, and it seems like all of the speakers were talking about like the key is access. Let's get access. And okay, a lot of places have access now, especially with digital health, but what are you doing after that? Like you can have access and you have these patients who get in the door, but how are you making sure that they're getting their medicines, the care that they need, the escalation of care? Because now we're putting a lot of barriers in place. For instance, there are a lot of digital front doors that are popping up where a patient has to jump through a hoop of going to a telehealth organization first before they can get in with a doctor in person. And we all know that I'm a strong proponent of telehealth, but we can't always reach out and touch you that way. So you need to see a doctor to be an adjunct to patient care. So once you get in and you have this access, what happens? Like, what can you do? And then what other barriers are coming along? I do still see patients twice a week virtually. And recently I'm licensed in, I think, 49 states. And which is a struggle in itself. We'll probably talk about. That's an issue. Like, why don't we have nationwide licenses? Like we have board certifications. Like it shouldn't be state based because you have to be licensed in the state that your patient is, and it costs a lot of money. But like, how are we able to serve more people if we have a clinician shortage? We should allow more clinicians to be able to serve. But now they're creating more barriers because there is the rule where you have to be licensed where the patient is. And one of my colleagues was licensed in the patient with the patient he saw, and the patient has insurance, and the insurance was through their job, which was also in their state where they live. But the company has insurance through a place. Let's say the patient lives in New York and their insurance is like, I'm making this up, it's not real, Blue Cross of Wisconsin. So the doctor went to sign the order for a test that they needed, and they were like, "Oh, you can't get it. You're not licensed." And he's like, "Yes, I am. I'm licensed here." So now the insurance company is requiring the doctor who's providing the order to be licensed in the state where they are, which is preposterous. Like, what about even primary care
What a mess.
doctors? They have one license. How are you going to get these patients what they need, and why are you creating more barriers? So thinking about
What a mess.
You got a great.
Add the nursing and the nurse practitioner layer to that as well, and it's the same situation.
Susan is always proponent of the hands and eyes, and that human intervention is very important for her. I agree, but I wanted to ask you that I was actually trying to interview the last AMA president, Dr. Jesse Unfair. Okay, he was supposed to, when he came on the board as the AMA president, he said that one thing that is in your field, he said that the universal licensing process for all the states you can work on. During the COVID, they did an emergency thing. After that, the second part of that is more important. What he promised is, even though I'm from Silicon Valley, I am not all into the blindly believe in technology in that sense. So liability issue that you are the majoring in, the EMR companies or these companies, healthcare app companies, they don't have any liabilities. You are the doctor and the nurses are liable for everything. That is unfair. So I said that he said that he's going to change that. Unfortunately, what he promised he did not deliver. I think this is a part of the politics. I think, let me ask you about the health risk assessment. You were talking about management, risk management for the organizations is a big thing, because as you said, there's you can hire any app, or you can bring any kind of a new technology there, but the liability goes to the doctor and a nurse, not for the IT company. So there's a technology company that brought that app. So explain to me a little bit about that, your ideas about it, and then I'll ask Susan also about nurses part of it.
Sure. And I think they all kind of come together just as teams. Like we have clinical risks, we're clinicians. So figuring out not only the clinical risk, but also like the liabilities of the organization, your reputation is at risk. And as we mentioned, like everyone is seeing certain organizations in the news a lot more than they would probably like. But there are some other ones that are slipping through the radar, and is kind of figuring out like what's next. How are you gonna avoid these digital health pitfalls that you didn't even know existed? Because a lot of times people are practicing medicine the way they've always practiced, but just online, throw it on a Zoom. But we can't innovate that way, and we can't continue to practice medicine that way. There are so many different liabilities now where you didn't have to necessarily think about it this way in terms of clinical care. So all of the guidelines in medicine are based on seeing a patient in person, because before 10 years ago, like that's what you did. So in the books and what the guidelines are and what malpractice lawsuits will come up for is, did you do that exam? Did you hear this? What did you do? So now people who are caring for people online, whether or not it's a digital urgent care, a specialty office, different things, they need to know now, what are the digital health rules? What are those workflows that help you triage or escalate to the next thing? When do you need to send someone in person? How do you communicate? Like, I think was in the video where we were talking about like interoperability and how can you communicate with more people? Why don't we have a system where you can share this information? Why can patients go from one office to the next office to this? And then how are you missing these risks? So like you were saying, in Silicon Valley, we have amazing solutions where people are coming together and they have the money to build these things quickly and bring on teams of excellent people who are well known, who are great business people. And a lot of times they don't bring on.
But where's the clinicians?
Yeah. So you
Where's the
build.
clinician? Where's the doctor? Where's the nurse? And they're so far upstream with this new innovation, which is so cool and going to be so helpful. It's an amazing solution. And then they've got to go back to ground zero because they didn't think of the things that the clinician, that workflow. I know you speak about clinical workflow, and everything has got to be human centered. So just quickly, you made me think of a story. I was just at a health tech conference too. And we walked, I said, and you keep asking, so what is your area of genius? That became my question. And the fella said, oh, we have this amazing app. Our app allows us to do all the patient assessments before they come in. We don't even have to, basically we don't have to see the patient, right? This app does the assessment before. And I'm thinking like, oh, that'll work. How does that work? No more humans in the middle of the assessment.
Exactly. And it's like they come in like with great intentions, but you have to bring that clinician in early, like as one of your first hires, like with the rest of the board, because there are certain nuanced things. Like there was one organization I worked with where, and Susan will know this, but like there's a balance with user experience from those different things. And they wanted to only ask what medication someone was on once, like on intake. But if you're having patients come every time, it may change. So we brought that up. I brought that up. And they were like, well, the patients don't like filling out the forms. And I'm like, well, what about the risk of if they went to the emergency, even if they came yesterday, if they went to the emergency room that night and they got a new medicine or a new diagnosis or something taken off and it may interact with something, your list may not be accurate and you're at risk. You're liable, or like you were saying, that actually the doctor or the nurse is liable because they're putting in the orders. So how do we balance that innovation and that move and that push for just doing things quickly with what is actually the standard of care of medicine, because it's really different and it's very nuanced. So that's what my organization helps, like bringing that clinical lens with the executive lens as well as the product development lens and marrying them together so that we can help people navigate through their strategy.
And not forgetting that human-centered care portion of it, which is like, I love the layers of your experience. I bet you what you learned and that when you were over those 5 clinics is kind of simmered up through all of this, because you're so human-centered with this. And I think in this huge data age with all the things we've just referred to, that is at the center, right? We don't forget that our patients at the center, the humans, and us being humans too.
Absolutely. And listening to our patients, bringing them on board to see what they need. Like they shouldn't be an afterthought. It shouldn't just be, let's see, a patient satisfaction score. Like they should be a part of the process, and they don't have to be, of course, like all your meetings, but you should have a way to incorporate your patients into what's going on.
You talked about a quadruple aim. So let's talk about that a little bit. Everybody is very much interested in the performance metrics, like population health, and my video is going crazy. But population health or the performance metrics, there's a lot of things are required. So quadruple aim is a great idea, but access is important also in this one. Tell us a little bit about that. What do you think of achieving that kind of a complicated aim? I was talking to Dr. Robert Perl, Kaiser, former CEO of Kaiser Permanente. He's talking about iron triangle. It's a very strong triangle, very unbreakable triangle. Is cost, quality, and access. These are either you can solve 2 of them, third one is going to sacrifice. That's what he says. You think that AI can shatter that? He believes in it. AI can shatter that triangle. So what do you think of that aims to be reached? What we need?
I think that it's something that we're aiming for every day, and it's actually evolved recently. I think they came out with the quintuple aim. So for those who may not know, you want to think about things like population health, like what Susan was saying, like the purpose, why we're here. We want to improve outcomes. You also want to think about what I was kind of talking about when that one particular team decided to unionize. Like, how do you support that clinician work-life balance and making your employees engaged and delighted to come to work? How do you also think about your patient experience? Like, of course, we want the great outcome, but we don't want them to feel terrible while we're trying to get it. So how do we keep them coming back and earn their business? And then you also want to think about, of course, like health equity. Like, it's very important. It should be the center of what every organization does, because not only is it the right thing to do, we know that healthcare disparities are what drives costs up. There was a report that said that they think that health disparities cost about $450 billion. So we can only imagine how that's going to go over the next few years with a lot of the changes going on in the system and with healthcare coverage and stuff. So that goes to the fifth part, which is healthcare costs. So how do we reduce these unnecessary costs and improve that efficiency while still not taking away from those other components?
Let me visit a little bit about the Susan and your situation right there. Access, for example. My father was a doctor in a small town in India, village. So what they did was, my father is a teacher also. They give with the villages, they don't have that much of infrastructure. They build a small quarters for these doctors and the teachers. They build a small quarters, so they have a school, they have a place to stay. All these rural areas, why not that? The problem is, I used to place a J1 doctors in rural areas. I placed more than 400 doctors across the country in rural areas, urban areas where the doctor shortage is. And the nurses, also traveling nurses, they need accommodation, like Susan is traveling in North Dakota. So I think, the hospital systems, health plans should create a infrastructure to do a good, if I'm going to Baxley, Georgia, or if I used to place a lot of doctors in Georgia. If I move to the Macon, Georgia, Savannah, Georgia, in a small town, that Baxley or Vidalia, you need to put some kind of a co-op buildings for doctors or nurses. They can stay there, and then this kind of a co-op area idea is need to come back. In my view, I want your opinion, both of your opinion on that. Access means not just healthcare access to patients, access to the doctors and nurses, the facilities, the school systems. They need to have some infrastructure in place for the rural areas. Let me ask you the first, Dr.
So you're kind of referring, I think, that as part of one of the aims is the provider experience, right? So is that kind of what you're getting at here, Ramana?
Yes, provider experience, and it's just experience
Dr.
means not a
Rowan, you
mental
said
health. Mental experience is a physical, all the comforts and the infrastructure and need in place. Yeah, go
I
ahead.
believe you said, Dr. Rowan, we should be delighted to come to work. That was a wonderful word. It's ringing in my mind, delighted. So I think, Ramana, I love the idea. So I don't know, what say you, Dr. Rowan?
I think that it's very difficult. I love the idea. I think that if we could implement it, it'd be awesome. But we have several barriers. So there's a healthcare provider shortage. So we don't have enough doctors now. We don't have enough funding for residency slots. A lot of them are going unfilled, and a lot of people are going to bigger areas. I mentioned that I did the National Health Service Corps, which does do some repayment of student loans, but a lot of people aren't necessarily going the primary care route. And I think that is even something that they need to address further back in medical school to even provide the care. We can't just put all specialists out in the rural areas. Mm-hmm. Then there are other barriers in terms of licensing for other professionals, like nurse practitioners, like physician assistants. Like, how do we do that? And some states have independent practice, some don't. Then we have the other things about like desirable, quote unquote, places to go, which is a personal preference for a lot of people. Like, do we incorporate some things like technology can help with that? There are some states in rural areas that have like kiosks at the bank or at the hair salon where people can go and get their certain care where there are more underserved areas. So how do we improve the digital divide where people may not even have internet access where they live? And then, like you were also talking about, a lot of the social determinants of health. And people who've heard me speak at other things know I hate that term because it's kind of like the common sense determinants of health. Yes, if you have food and access to care and education, of course you're going to be healthier. But how do we put that into different communities, making sure that they have these access to everything and not just access on paper, but making sure that it actually fits what the needs of that specific population are?
And I think it's also about taking a lot of the existing services. I don't think there's enough collaboration amongst existing services. Mm-hmm. I mean, within one city, right now, I work for the Heart Safe initiative from the Citizen CPR Foundation. And in so doing, we discovered, like, if everyone in the community came, we'd like basically dump what you're doing on a table. And we see that we're reproducing a lot of the same things. I mean, a lot of us are doing a lot of the same things. So we can, never move a heavy load more than you need to, and collaborate more where, for instance, there's money right now, money's going out for rural areas. And in order to get the money, it can't just be a one healthcare system that wants it. They want all the healthcare systems to talk about, how can we spend this money as a community? How many community members can we bring in for one tech solution or one workforce development solution that we all share? So just that alone kind of excites me about pulling together what's existing, for access. If you pulled us all together and had, I use libraries or fire departments that we could be hubs for this type of a communication.
That's where AI can play a role. I tell you,
Schools,
AI
schools.
can play a role.
Yes, very much so.
That is a very, let me ask you, Dr. Rowan, can you give me a rundown on, if you go to an organization, what kind of things you do? Suppose they're all shattered around the disorganized system they have. What do you suggest? Where do you start from a burnout to all the way to the existing system? How do you, what kind of things you go through?
Absolutely. So I think it all depends on what the organization needs in terms of the risk. So I'm sure everybody always thinks like, oh, we have a legal team. Oh, we have a risk management team. But it's a difference with clinical and digital health risk management. So number one, we need to do a needs assessment. We need to see where they are. We need to look at their infrastructure, and we can help with different things under different prongs, like under risk management, making sure that they have the proper risk infrastructure design, that they're continuously looking and reviewing things, that they're trying to point out ways in which they can improve their outcome, that they're preemptively detecting risks. Not just, a lot of times there are a lot of organizations that kind of see something and then they're having this reactionary response. We should be proactively planning for things to happen and thinking about it from other situations, making sure that you're staying abreast of the regulatory and policy changes. We can help with that in terms of policy and compliance navigation. We can partner with, you always need legal, but partnering with them and making sure that things are up to date, having crisis preparedness, because sometimes we've seen these organizations that are in the news where they're sharing data, where they've been hacked, where they have patients who've had near misses. I know there was a big thing, I think either earlier this year or last year, with Amazon online, where they had a patient, because you got to work on different things. They had a patient who actually came in online with a complaint of shortness of breath. The person perused. I don't know if it was via text, because there are some text-based organizations versus video, but they had a history of asthma. The person was like, oh, you need a new inhaler, sent it to them. The person died before they could pick up their pump because it wasn't asthma. So how do we prepare for those crises, and as well as how do you have these corrective action plans for when things happen? And then how do you work with your clinical workflow optimization, as well as working on that AI governance aspect that a lot of countries are way ahead of us on? I'm going to be speaking with the WHO, I think in a week or two, where we're talking with Portugal and how their smaller community health clinics in rural areas are working to incorporate AI, and using some of our examples of what people are doing well. And then how do we not only do that, but how do we train how to do these things? So I've been speaking with some pharmaceutical companies at some conferences and things like that on how can we think about risk in a way in which we can do all of those things proactively, as well as how do you bring your team on board? Like, we like to think of stuff a lot from the high level, but the people who are doing the work need to understand why, so that they can get on board and they want to use it. I think about a year or so ago, Kaiser was in the news because their nursing team was so upset that they were going to utilize AI in order to help with medication management and some of the patient care. So they were concerned and they were about to go on strike. They could have avoided all of that by just showing, this is what we're trying to do. This is why we're trying to do it. This is how it's going to help you. We're not going to fire you. This will help you use your license better, and you will have the overall say on if the medications will be released. But if you're just saying, this is what we're doing, this is how we're doing it, go do your training next week. It's not going to work that way. So how do you prepare your teams in terms of like a change management thing for this? And that's what our organization can help with.
Yeah, and do you find with your the shiny new thing syndrome? I mean, when you're speaking, so many things are going through my mind. They're tech stacking, and now we have the new greatest thing. Going back to the nursing and the nursing workforce in your example just a moment ago, it all goes back to education. Not only, I mean, how much education can staff assimilate before the next stack and the next shiny thing? Without, I mean, I hate the word burnout because I'm burnout on the burnout. But to your point, when you go in, are you finding that education for the clinicians is keeping up?
Well, I think that education is powerful. And we can definitely see, to be honest, I haven't done as many of the hospital level trainings, but from the conferences that we've been through and some of the smaller organizations and some of the pharmaceutical companies that we've worked with, where we're talking about why and how, they just ask for more. And they seem really engaged and they seem to understand it. And then we talk about the risk. And I think that it also brings a conversation that continues. So I think a lot of this is about sparking conversation, making places to work psychologically safe, where you're okay to speak up. I think is the biggest thing. And then where you also are aware that this isn't just click a button and do it for me. You have to have that oversight and you have to realize that a lot of the data, like AI, technology, it's trained data. So where are we getting this data? Are we incorporating bias? Are we incorporating errors? Like there was a big thing where a hospital was using a sepsis risk calculator and it was incorrect. So they were missing people. So who's overlooking that? And do you feel comfortable enough to speak up? Or are you just saying, oh, they said I got to push the button. I don't want to get dinged. So you have to create this culture of speaking up.
Both I'm a minority here. I'm a only man. There's two women up here. So you're a very powerful woman. So let me ask you a question in the woman's health. Let us talk about a little bit about both you that what is the access to mammograms, breast screening, other areas, menopausal problems, and all those things are there. Women go through that man has a different problem, but that is a big problem. What do you think access, quality, and the cost of this whole process? Both of you can answer that, actually.
Listen. You just had a very cool article, Dr. Rowan, on I read the whole thing. So I'm going to let you go because it was about, where we are on femtech, the money, the research, they're removing women from, we just barely got back in the conversation. So I'm going to let you go on this because it's a pretty powerful piece.
Oh, thank you. Well, you just summarized it, but femtech it's been quite an interesting ride. So in the 1990s, like up until the 1990s, women weren't even allowed to be participate in research. So mostly all of the medicines that we have are based on males. So there are so many avenues and areas in which we can push forward women's health. And with femtech, it's been a little boom. A lot of organizations and a lot of the different sectors that you mentioned, like menopause care, breast health, radiology, women hormone health, weight loss. Like there's so many different places in which women's health can be impacted, and they're growing. But we also see with a lot of these startups that it's not getting funded. The ones that are being funded aren't founded by women, and not saying that organizations that are founded by men for women can't do well and they aren't going to have a great team. But sometimes, a lot of times when earlier companies start, their founders have that passion, and women have passion for women's health. So how do we keep pushing it forward with a lot of the different financial constraints that have come up over this past year? There's less funding, there's lots of things pushing back. So the Gates Foundation came up with some funding in terms of research recently. That's very exciting, but we have to push for more. Like we have to do the research 100%, but what about the companies that we have out now, and how can we push for employers to even think about women? So a lot of times in some other companies, we love to talk about, there have been some great strides in terms of maternity care, in terms of figuring out, I was at another conference recently where I met with a founder who was a male who was very passionate about making sure that women have safe deliveries, and if they're in a rural area, they get to the place in time to deliver at a healthcare facility. So he created a tokometer, which basically measures those contractions, and it tells women when to go in. And it's been pretty accurate according to them, where they don't have to go to the labor and delivery unit and they get tested and they're like, oh, you're not in labor. You go home for another 4 or 5 hours. So it's helped women in that way. There have been some other organizations that are working to help make sure that women are getting access to menopause care, which has never been talked about before. We have people who are helping women navigate through fertility issues and getting more coverage with that, which we are seeing more women needing that help because more women are in the workforce. We're starting families later. So how can we help these women with this extra technology? But outside of women's health, in terms of the GU system or the genital urinary, I always tell women that it's more than your vagina. So go get your primary care in addition to your wonderful gynecologist, because you are more than your vagina. Your heart exists, your brain exists, all of these things. So you need to have all of them checked out. So how can we work in terms of women's mental health and Alzheimer's prevention and cardiac health? Women, number one killer, cardiac. So how do we advocate for this and then also get employers on board to adopt these things is very important.
You're so bubbly. So yeah, I'm not surprised that you have 18,000 followers. I tell you that you should run for. Have you ever thought of running for an office,
Oh
Dr.
no.
Rao? Yeah, she's not bubbly. Let me. Okay, now while you're thinking about that, I'm going to introduce you magic of AI, and I'm going to talk with you a little bit about the story about something interesting. This is the in 2015, there was a beauty pageant happened in Korea, South Korea. South Korea is the capital of beauty pageants and also plastic surgery, right? So the judges, they said that they all look same, eerily similar. It's not the Indian telling all the Korean looking same, but the Korean judges were telling they all look same. They were all surprised. What the hell is going on? So the journalists tried to do inquiry about that. That's what they found out is they went to a place called Gangnam Golden Ratio Plastic Surgery in Busan, South Korea. They went to same plastic surgeon. They want to look like the Charlene Choi. She's a famous Hong Kong actress. They want to look like her. So everybody, they don't know each other. Everybody want to look like her. So the guy wants to make money. He just made everybody look same. That's a very strange, but there's a name I want you to read that. Gangnam Golden Ratio of Plastic Surgery. It's a golden ratio name. Why did that come up in the golden ratio? That is I'm going to talk about. The Greek fighters is a Phidias, is a Greek god of beauty. That's what they say. He followed a golden 6 foot tall. He has a if you have a novel to the head and a novel to the bottom of the feet, if you have that ratio, the golden ratio is 1.6. If you have the ratio 3.3 feet 8 inches in the bottom and the 2 point, that's a kind of a beauty they described in the Greek philosophy and Greek mythology. But this is followed by golden ratio. If you want to have lips, you don't need to worry about both of you beautiful women. But there's a lot of people want this kind of golden ratios. They want to have the lower lip and versus the upper lip. This a big ratio. So a lot of plastic surgeons follow this golden ratio. Eyes versus same thing. You can do all those the entire thing on the golden ratio thing. So where it started, that is a very interesting. It started in the 1100 AD in Italy, in the Leaning Tower of Pisa, the city of Pisa. It started. The guy was studying. This is I tell you how that golden ratio came into this our scientific world. 1170 AD, Leonardo of Pisa. In Italy, the people who were born there in Italy, that they were called their name and their name of the town. Leonardo of Pisa, they call. So he was born in Pisa in the Leaning Tower of Pisa. His father was a naval merchant. Okay, so he was traveling to do Sardinia to Africa. Sardinia to Africa is a 200-mile journey from Sardinia to Araba, Anirba, Anaba. Anaba is a port in Africa, in Algeria. So they were traveling. They're exchanging they're taking goods from Sardinia, Italy to the Anaba in Algeria. So that is a naval merchant. His father is a naval merchant. So Leonardo was a young man. He was traveling with him. He was traveling with Algeria with his father for the learning about the tricks of the trade. I think what they do, the Italians are. His name is actually the latter name changed. Is Fibonacci. Fibonacci came before Marco Polo. Marco Polo entered India, China. He went all over the world. So in the East, at least, is a before Marco Polo. Fibonacci was the Italian hero traveled to Africa. What he did was, what they're doing is they're doing a lot of armor. Italians are doing armor and wine. They're exchanging with the spices and gold. Their Arab merchants are bringing the Arab and African merchants are bringing spices and gold from India, and then they're bringing there, and then they're taking the armor and wine. They're exchanging these ideas. So they goods. So during this process, one thing Leonardo Pisa was watching something interesting. Roman numerals 1, 2, 3, as you know, I cannot say that it is a representation of the Roman numerals they follow in Italy. The Italians follow the Roman numerals. That's a very established numerals. African merchants are doing a different kind of a mechanism, different kind of accounting they're doing. And he saw something. He saw 88, for example. He saw on the left side like a 7 digits. Here is a 2 digits they're representing. He was surprised, and also he was surprised about one particular item is called zero. So Leonardo Pisa was surprised to see zero in the African merchants calculating their counting the goods in the different counting arithmetic they are using, the different mathematics they are using. What they found out is that Leonardo Pisa was very young man, wanted to learn. That is what Hindu Arabic numerals, they got it from India actually. Arab merchants going to India and bringing all the spices and gold, they are learning from India the zero. Zero was actually started in India, Hindu Arabic numerals, that is what they started up there. So African merchants are using a new kind of a counting mechanism. The place value 600 BC Gwalior temple in India, they started zero, started there, Sunya the call. So the place value 600 AD is started 10, 100. The place that zero is in, it defines the place, the value of that digit or of that value. So they've been following decimal system based 10 system for a long time. So African merchants are using Hindu numeral system. So then Fibonacci was a young man. He learned quite a bit he loved this new math, and he wrote a first mathematics book in Western world. Liber Abashi is a book of calculations. He did start that. It is called, he wrote in that book, he wrote a modus synderum. It is a modus synderum means method of Indians. That's what the zero was invented there. He was using zero method. That's the first Western book. That's what he did. He's actually introduced the zero numerals 10 base system to the Western world through the Arab merchants when he was he's the first father of mathematics, Leonardo Pisa. That Fibonacci, they call him Fibonacci now. But and also he did something interesting. He came up with a sequence called Fibonacci sequence 0, 1. If you added back two numbers, so previous numbers he had 3 plus 2, 5. 5 plus 8, 13. 13 plus 20. So you were adding, they created a sequence. It looks a simple thing, when you divide the previous number to the 13 by 8 is 1.6. That's the golden ratio. That's where the golden ratio is coming from. 21 by 13, 1.6. 13 by 8, 1.6. 8 by 5, 1.6. That's where the golden ratio. Something we found profound in the nature, Fibonacci sequence. So the Fibonacci mentioned about the sequence and the golden ratio there. So then, one the nature, actually, if you see the flower petals, they all follow 2, 3, 5, 8, 13. The numbers, petals, you don't see 4, you see 5, you see 8, that's 13. The nature also following Fibonacci sequence. That's a very strange sequence that interestingly, even our Fibonacci, our biology in the our fingers, the first, if you do the 5, 8, 13, that inches wise, that it follows the Fibonacci sequence. So the previous number, Fibonacci in stock market, the stock market, they follow Fibonacci. When it's going to go up, the stock's going down. But the ancestry, we want to know who is the first person in our gene pool. You have to use a Fibonacci sequence to go to the number one man in your gene pool, number one person in your gene pool. You can find out through Fibonacci sequence. So then AI designed a human body with a Fibonacci sequence. Golden ratio is the two numbers, right? AI created a golden ratio 1.6. That is these young people, AI guys, do that kind of crazy stuff. But they did. They found out actress Helen Mirren is a perfect body for that, and then the actress Halle Berry. They're all those. You don't need to worry about. You're both beautiful women, but they're all. But this is a AI came up with this kind of a two people. But beauty is a wrong standards. Beauty is in the eyes of the beholder. You have to, once you see the mind, knowledge, intelligence, smart, and humor, all of those things are important. So there is a Korea. There is a movement started. After this program, after this contest, everybody got fed up with it. They started a movement called Corset, against the plastic surgeries. But actually, that is where Fibonacci sequence you see everywhere in the nature, not only in biology, in medicine. It's systolic versus diastolic pressures. If you want to have a diastolic versus cardiovascular disease, a great biomarker, Fibonacci sequence is golden ratio. 130 by 8, 80, that's a golden ratio 1.625. So that is really, even in the blood pressure, you can see the Fibonacci sequence presence there. But not only that, that is a good marker. In the gait analysis, people walk. If you take an iPhone and do that, the Lagrangian mathematics you can do is a biomarker. You can detect the Parkinson and Alzheimer's and MS. The steps the way you do it. Is a gait analysis it does by just if you put that mathematics into it in the Parkinson, Alzheimer, and MS, it can detect all the gait analysis through the Fibonacci sequence. So it's coming a new kind of now breast cancer, for example. Let me tell you, you need a mammogram, you need a breast MRI, but they found a patch, Fibonacci matrix patch. It's a patch. What they do is, if they put on the breast of the suspected breast cancer, it tells you the temperature variance. That matrix will tell you that is a malignant. A lot of times there's a calcification for the breast, and a lot of people I know, I remember we used to offer a mammogram test for a lot of people. A lot of calcification look like a suspicious, but in fact, to find out, if you use that thermal patch, it can tell you it's a malignant or 98% sensitivity. It can tell you whether it is a cancerous or a benign. It's a new mathematics Fibonacci sequence is giving. So you don't need all the PET CT scan, MRI, CT scan. You can do through the mathematics, you can detect cancer. Fibonacci is a mathematician. He came up with a golden ratio. Siemens, for example, now 2025, Siemens, and just today, in fact, very interesting, GE Healthcare bought the Icometrics company. It is based on a Fibonacci sequence. What they do is it is a Alzheimer's disease, detection of Alzheimer's disease through the folding in the brain, the white matter. So just the body today, the Icometrics is based on a Fibonacci sequence, Fibonacci mathematics. Then the examples of the Siemens is doing a very good for example, to the medical imaging, MRI imaging, they can go through the Fibonacci sequence. You can go through that. And the cancer dosage, they were saying that if you follow Fibonacci sequence, the periods you administer the chemotherapy through the Fibonacci sequence 5, 8, 13, it is getting the better results. Stanford is doing that research in Mayo Clinic. It is Fibonacci 1,000 years ago. He came back with a wonderful mathematics and a golden ratio. That's the beauty is in the saving lives, not in the physical structure. But Fibonacci is this new mathematics. Fibonacci is the beauty is in the saving lives. Thank you for watching. Let me bring the wonderful ladies and ask them.
That's
Yeah,
fascinating.
yeah.
Wow. And we've had the answer all the time. We've had these answers all the time. Isn't that crazy? You bring up AI now from something from 1,000 years ago.
1,000
You
years
use
ago.
math from 1,000 years ago. And look how many doors that has opened. Isn't that kind of like matter's neither created nor destroyed? It only changes shape, right? So we just applied this math in a different manner and look at all of those amazing things.
So, Dr. Roman, the thing is, I think AI, in my view, can bring the very simple. You don't need a big test, MRI, CT scans, all those. You can reduce that into the algorithms, into the small mathematical algorithm. Small variations it can detect cancers and all those serious problems. In fact, that is the one thing the new mathematical process. They're doing even prostate cancer. They use a Fibonacci kind of a sequence. They're using it, not the exactly Fibonacci sequence, but they're using the mathematical statistics to detect cancer in the prostate cancer. So I think these are the new tools. People like you can deliver the care cheaper, better, and access is wonderful to that kind of situations. So let me ask you that questions, a little bit. What do you think? What do you need? Why we need to change the healthcare system in this country? It is a very sad situation we are in. The American healthcare system is a paradox. It is a lot of advanced technology there, and people are struggling. What do you think?
I think that I'm still fascinated by all of that math. Susan and I were talking before we got on about how we were like,
I was thinking the same thing.
but I love the idea of what the possibilities are for AI. Like you were saying, like we're diagnosing cancers earlier, all of these different things. That's why I think I was talking to someone recently and I was like, a lot of the conferences and things have been revolving around AI, and we're all talking about like what could be the possibilities, the vision, the future, our thoughts. But what ways can we apply it now? And how can we push it forward to get to that point where we're not just talking about transcription services? And yes, that's needed. But how can we get to getting more people not only in to get that care, that access to it, but what are we going to do when we have the capability to get 500 women screened for breast cancer in a day while using this and getting it to be accurate, making sure that the vendors who are selling these things are chosen wisely and we're not jumping into conclusions, but having things that are validated and tested and accurate so that we can move on to helping the next thing. Like you said, we have so many resources, so many intelligent and smart people from all sectors. Like, how can we come together and use that power for good? So I can't wait to see what we do with this stuff.
So Susan, so your take on that,
Oh, I'm in it to win it. And so what we were saying at the beginning, I couldn't believe he's going to get into math. I mean, we just talked about this at the very beginning. I'm thinking, wow, and he's getting really deep into this math. And so I just like buckle up, hang on. I hope he's going somewhere where this doesn't hurt so bad. So anyway, it was a fascinating education piece this evening, Romana. Really, I appreciate it. And when you bring from 1,000 years ago up into today, and just to summarize, it all comes back to the care that how exciting, what an exciting time to have such capabilities to do the same things that they were needing 1,000 years ago, right? I mean, we all have the exact same needs that they had back then. We have today, and we have so much technology. And yes, it is a scary place, our healthcare system. But I think with all the people with our hearts are in the right place. Like Romana was saying, if we can get everybody just to come together, use their hands, their eyes, and their brains, we can then put together this technology for really, really, really good use. It's just going to take that human hands, eyes, and brains, I think, to pull it together.
Dr. Kera, what do you want to see in the future? What do you think we need healthcare should be if your ideal situation there? What is ideal situation for you in the healthcare?
Oh, that's such a wonderful question. It's kind of
Yeah.
big, but I think what we were talking about now, like getting those resources to people where it actually matches what they need. Everything isn't for everyone. Like men don't need a mammogram, so we're not going
Mhm.
to bring it over to them, but like women do. So how can we do personalized care, which AI can definitely help with? How can we create personalized medicine so people will have less side effects, things will work better? We're seeing that more in the mental health space, but I'm sure it will expand. How can we have interoperability so we won't do repeat testing and we can get to answers and solutions and improve outcomes faster? How can we have more data ownership that can also help with getting to those solutions where, in other places, patients can have like a little device or something where they have all of their healthcare information there. And yes, we have portals, but how can we make it easier for patients? How can we have more wearable integration that's actually moving things forward? Because now we have the opportunity to experience healthcare at home. We need to utilize it to its highest potential. Like, yeah, we have Zoom, but are we using it to go and look at people's refrigerator and do AI evaluations on what can help them with sustaining their weight loss, help them with their heart health, their diabetes, all of the different things? There are so many opportunities, but with opportunities comes responsibility. So, how do we use this stuff responsibly? How do we incorporate it and not go too fast, not go too slow, and make sure that we're looking out for those risks and we're proactively planning? And how do we protect patients and protect data?
No small feat. No small feat.
We can date in 3 months by the end of the year.
Yeah. Dr. Kera, you are a leader in making with all the qualifications. You are down to earth. It is a real humility. You're really why people love you. I understand now. I think people like you. We need more and more people like you. And think you need to profess your philosophy of care. We need to take them to the next level. People like everybody. We're in the same boat. Thank you for coming on the show. It is truly an honor and privilege to have you.
Thank you
Very
so
much
much
so.
for having me. It was such a great opportunity to speak with you guys.
Thank
Thank
you.
you so
Good
very
luck.
much.
Bye,
Be
all
well.
of you. Yeah. Oh, yeah.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.